Hi, and thank you very much to the Vietnamese Society of Radiology and Nuclear Medicine for allowing me to present today from stenosis to myocardial viability in cardiac imaging. Hi, I'm Professor Charbel Saade, the Global Director for GERBE and also Professor of Radiology at the University of College of Cork in Ireland. So in today's lecture, we'll talk about a little bit of coronary CTA, the impact that accuracy has on iterative reconstruction, CT FFR, and then we'll go into myocardial viability, anatomy, microvascular obstruction, and viability, and just show how it is not all as simple as what we think it is. Just a disclaimer, the statements made in this presentation reflect only my personal opinions and experiences and do not necessarily reflect the opinions of GERBE or any other institution which I am affiliated. Regarding the pharmaceutical products and medical devices mentioned in this presentation, please refer to their local summary of characteristics and/or the instructions for use. Trademarks are the property of their respective owners. We're looking at coronary CTA. The important aspect is that we should always scan our patients, especially in Asia. Patients are usually below 75 kilos on average between males and females. So we should always be scanning less than 100 kVp protocol. This is shown quite a lot in the Protection 2 trial, that there was significant improvement in image quality below 100 kVp, which also allows us to get to the K-edge of contrast, which is about 90 kVp. Even if you have iterative reconstruction, you'll get even better with 80 kVp. Clinically, if we look at both 100 and 120 kVp in these two studies, technically they're quite good. 100 kVp shows 577 Hounsfield units, whilst if you look at 120 kVp, it shows 410. Both are still acceptable as long as it's above 350 Hounsfield units. You can make a very confident diagnosis and it won't impact your lumen nor stenosis measurements. So there is a lot of controversy that's happening these days, especially when we're coming to look at the iodine delivery rate. So in this study that was actually published in 2020, when they looked at coronary CTA protocols, they looked at the conventional CT at 120 kVp versus slow injection rate, short duration or fast injection, low concentration, or a combined method. And interestingly, it showed that the IDR was at 0.7 for the conventional technique. It was, injection flow rate at 2 mils a second for slow rate, 4 mils a second for short duration, low concentration at 4 mils a second, and of course the combined method where they looked at the IDR of 1.4 having a high flow rate at 4 mils a second. Now keep in mind, all of them used 350 density contrast. You don't need more than that in terms of concentration because you're using a lower kVp, you get higher Hounsfield unit. As you can see here with this iodine delivery rate with the 5 different conventional protocols, you can actually see that the combined method as well as the low concentration and the conventional technique showed a closer and more compact in terms of image quality and Hounsfield unit density. Whereas if you use a short duration, which is really a higher flow rates, you tend not to get a nice variety because it all really depends on the cardiac output of the patient. So for example, if I'm using a 400 density contrast and I want an IDR of 2, we still need to go 5 mils a second, and this is also too bright for the lumen. Let's take a look here. This is a paper that we recently published a few years ago where we looked at the iterative reconstruction and its impact on image quality and qualitative impact it has on both radiologists, cardiologists, and resident radiologists. What we found was with filtered back projection relative to hybrid-based iterative reconstruction up to ID6 versus model-based iterative reconstruction. So if I take both extremes, when I look at the filtered back projection, we see there's myocardial bridging at the right coronary artery. And then also, if I take it, for example, here, this is ID4, you can actually see there's a lot more clearer information and it looks a little bit wider. When I come back down to model-based, which is this one here versus hybrid, you can see that this is more glossy, but you can actually see a nicer, smoother outline, and there's less noise sitting around the lumen, which shows us a very rare right coronary artery myocardial bridge. And also in another study that was actually published not too long before that, it was shown that the sensitivities in terms of coronary artery stenosis for lumens greater than 50% has a 95 and 90% for detecting significant coronary stenosis. Specificity has been reported to be around 79 to 83%. So these high sensitivity and specificity values indicate that iterative reconstruction in coronary CTA is quite effective in accurately diagnosing coronary artery stenosis. We've started to move away from coronary artery stenosis in its terms, and now we're starting to look at CT-FFR. Flow reserve has a 95% diagnostic accuracy. It has a 97% intra-observer reproducibility. It does avoid a lot of complications associated with pressure wires and hypoanemic drugs. It has a faster workflow between 5 versus 7 minutes, 68% pressure wire and adenosine-free procedures, and hybrid favors angio-derived FFR. Looking at the FFR, it's the ratio of maximum flow in a stenotic artery to maximum blood flow in the same artery where normal. Now, if a fractional flow reserve versus angiography for multi-vessel evaluation, the use of FFR to guide coronary intervention compared with ICA guidance results in a 33% reduction in major adverse cardiac events. So here you can actually see the difference between the subepicardium and the subendocardium when you're looking at coronary flow between pressures depending on the mercuries. And we know that an FFR of 1 is widely accepted. An FFR lower than 0.75 to 0.8 is generally considered to be with myocardial ischemia. Now, these indications are really important to identify culprit lesions. Sometimes you could have a stenosis, but the FFR is 0.9, so there's no intervention that's required. It's the ones that are below 0.75 is where you really need to start considering coronary artery intervention by using either a balloon or, of course, coronary stenting. Now, we know that FFR is not influenced by changes in blood pressure, heart rate, or contractility. It has a normal value of 1, and FFR incorporates the contribution of collateral flow to myocardial perfusion, and this is critical, especially when we come to look at microvascular obstruction when we're doing cardiac MRI. Here, if you have a typical diagram here, the total pressure drops across the area of the stenosis, which is governed by the 3 hemodynamic factors, such as viscous losses, separation losses, and turbulence. Calculating the FFR, they look at the proximal pressure, which is, divided by the distal pressure. So distal pressure divided by proximal pressure. And this is how we calculate FFR. We're looking at FFR and you're looking at a patient who has an epicardial coronary artery resistance. We look at microcirculation. Is it intramyocardial capillaries versus collateral microcirculation? Now, if I have an FFR of less than 0.8 coming down into FFR of 2, this patient does need a PCI treatment. If there's no flow limiting stenosis and there's preserved microvascular function, medical therapy, no PCI required. If, however, your CFR is greater than 2 and your FFR is still less than 0.8, you have flow limiting stenosis, microvascular dysfunction, you must have a PCI. And if your FFR is greater than 0.8 but your CFR is less than 2, then of course you would need to have medical therapy and no PCI. And this is critical here. If you can remember these 4 critical areas, if FFR and CFR, this will give us a really good indication on patient outcomes. Now again, when we're coming to look at this fractional reserve and coronary reserve, I always like to look at my CFR if it's greater than 2, if there's no limiting disease, only need medical treatment, or if it's normal. If there's flow limiting disease less than 2 with an FFR of less than 0.8, here this area from 0.3 to 0.8 must have definitely a PSI. Take a look at typical normal examples of a normal FFR versus an FFR. Here the stenosis is 70% stenosis and the FFR is 0.7. Here you have an FFR of 1, so definitely this will need PCI. Benefits of using FFR in CT. Let me show you a case. We have a 73-year-old male. He has a checkup due to chest pain on exertion. Scan findings demonstrated calcified and non-calcified structures or deposits in all 3 major vessels, and there was a moderate stenosis in the LAD. So here you can actually see this is your axial MIP image. You can see your coronary calcium deposits as you can come through with your circumflex, your LAD. You can see them quite nice in the right coronary. And to produce the FFR, it actually showed that on the distal circumflex, the F stenosis was 75 or 0.75 down to 0.72. There's no FFR CT findings in the right coronary or in the LAD, so definitely this patient needs to have a PCI, coronary intervention, or potentially a bypass if it's heavily diseased. Look at data and stenosis. It's not just related to CT. We also need to confirm the impact that the PCI has on the actual outcome of the coronary CT. Look at the first and second cases here. You have a culprit lesion here with an FFR of 0.65, as you saw in CT, and here it's 0.62 on CT versus interventional cardiology or radiology. Again, this patient does need a PCI. If you have a look at coronary CTA, there is a stenosis. Here you actually see a 0.86. There's no ischemia, and on CT is 0.87. This patient doesn't need to have a PCI. They can just have medical therapy. And here, if you look at per patient diagnostic performance for intermediate stenosis by CT, the sensitivity and specificity is sensitivity and specificity can be mixed. So the accuracy between FFR and CT versus CT in more than 50% stenosis is actually 73%. Sensitivity is, there is a mismatch between CT and sensitivity, but the specificity, positive predictive and negative predictive values, there is statistical significance as well. When you're also looking at an intermediate stenosis, so for example, here you have in CT, you have a nice, you have multiple calcifications. When you went to the cath lab or into interventional radiology, your FFR distally was 0.74. Definitely this patient does need to have PCI. So when we're looking at FFR, it demonstrates improved accuracy of just CT diagnosis, especially at 73% with a 95% confidence interval at 67 to 78%. The pre-specified primary endpoint is more than 70% lower bound. The FFR CT is superior to CT for intermediate stenosis. So CT is just not enough anymore. We need FFR. Now, it's also done without any extra radiation dose. And of course, the feasibility on a lesion-specific ischemia has been demonstrated. We know that we have stenosis, we have CT FFR, but sometimes this is not available. So let's look at late gadolinium enhancement. Whenever we're looking at late gadolinium enhancement, we have to remember not all contrast agents perform the same way. Because if you think about a 0.5 concentration versus 0.1, ideally when it comes to body weight, they're still the same. So let's just take a look. If I wanted to look at the optimal time with I'm using single or versus double dose, 20 minutes between blood and myocardium at 1.5 and 3 Tesla shows me the greatest mismatch or the greatest difference between blood and myocardium. These days at 0.2 dose, we don't use this anymore because of the sensitivity of our coils picking up this really good image quality. And if you're looking at microvascular obstruction, and remember, microvascular obstruction can come from a stenosis and also from not a stenosis, as we showed you a few cases before. And in MRI, if you look at 2 minutes post-gadolinium, you'll actually show a decreased hypoperfusion. At 27 minutes, you'll show it as increased microvascular obstruction. Later, I will show you how we work this out and how we go about it. We also look at, blood and gadolinium. When do we look at, normal myocardium? So under the American Heart Association, they usually say 8 to 12 minutes is really good to look at the difference between normal myocardium versus ischemic and the blood pool. But in actual fact, 10 to 20 minutes will show you the difference between infarcted versus ischemic versus the blood pool. It's a lot greater, and this is what we want to aim at. And I'll show you the information, and let's go through the anatomy as to why this occurs. We take a look at the myocardial anatomy. Our blood supply, basically you have your class A vessels which come from your subendocardium versus your class B vessels which come down and provide blood supply to the myocardium via the subendocardium. Now these class A and class B vessels change during contraction. At end diastolic phase, when you're having maximum relaxation, your class B vessels actually get really good flow of contrast into the subendocardium. On the systole, it actually disappears and is also less. So imagine contrast going in, contracts, contrast coming back out, contrast going back in, and slowly perfusing the coronary circulation. Here, if you also have a look, when we're looking at patients that have good collaterals versus poorly collateral vessels. Sometimes patients do have poor collateral vessels that are developed, and so that's why 8 to 12 minutes does not do you justification in cardiac MR. You need to actually wait up to at least 15 to 20 minutes in order to get a really good imaging in case you don't have very well collaterals. So if you have a look here, when you're looking at the segments here, if you look at viability, a lot of dysfunction happens in less than 50% of cases. And this is quite large with poorly developed collateral versus well-developed. So here, this is critical. When you do late gadolinium enhancement, there is a mismatch between anatomically good collateral development versus anatomically poor collateral development. So let's talk about myocardial viability now and go into a little bit of protocol, and let's get into the radiology of it. I'd like to use 20 mils of GAD, 4 mils a second. Love to use 60 mils of saline. And as we know, saline actually gives you more water molecules around the gadolinium molecule, which in turn gives you significant increases in attraction and relaxation between the gadolinium ion and the surrounding water molecules. So let's take a look at now myocardial infarction. It may present as a reversible myocardial dysfunction in association with reversible ECG changes and angina pectoris. But also additionally, consequences of myocardial ischemia include myocardial infarction with permanent contract dysfunction caused by severe long-term ischemia. You could also have a hibernating myocardium, stunned myocardium, or a preconditioned myocardium. So if I had an ischemia, had a preconditioned myocardium, the body goes into protection mode where you have permanent contract dysfunction and you have a myocardial infarction. If not, it might go into protection. You could have transient post-ischemic dysfunction, which then turns into a stunned myocardium. Or if it's chronic with reperfusion, you could have a hibernating myocardium, which then relieves of ischemia to turn into a stunned myocardium. Now, this preconditioned myocardium may in turn offer protection during a subsequent ischemic bout and has been demonstrated to reduce infarct size in animal models. It is not clear at present whether its preconditioned myocardium is capable of having recovery of stunned myocardium. And if we go deeper to microvascular obstruction, usually when this occurs, if we do or don't have an obstruction, here you could have endothelial blebs, you can have myocardial swelling, you have endothelial damage leading to intramyocardial hemorrhage and interstitial edema. You can also have vasospasm, distal embolization, or platelet leukolyte plugs. Now, one thing I forgot to say is if we're going to wait for the recirculation at 20 minutes, This is because, remember, the half-life of the radiological profile of gadolinium is 5 hours in the blood system. So you can inject it, get the patient off, do another scan and get the patient on 1 hour later, and you'll get really good results. We're looking at the microvascular obstruction. I just want to go a little bit further into more detail as to what really happens. Really, there are 4 interacting mechanisms in microvascular obstruction. Usually there's ischemia-related injury, where you actually see it coming from here, distal embolization, and of course individual susceptibility, both genetic and due to pre-existing coronary circulation, so you have the incisions there. And then of course you have your genetic variability, diabetes, which could be a problem, as well as of course reperfusion related injuries. Now here what happens is, here you have an endothelial protrusion, you have endothelial gaps with extravascular erythrocytes joining, you have platelet and neutrophil aggregates, then you have myocardial swelling. This is what we've seen before. Then you have vasoconstrictor substances, then you have interstitial edema and obstructive emboli. This is what starts to occur from proximal to distal. You're looking at gadolinium enhancement patterns. You can look, for example, at right ventricular overload. You can have mid-wall. You can have myocarditis, sarcoid or Fabry's or Chagas disease. If you have subendocardial, this is mostly due to systemic diseases such as amyloidosis or cyst sclerosis, tumor infarctions. And if it's epicardial, of course, you could have Fabry's, Chagas, and myocarditis. But of course, in injured myocardium, the washout is very, very slow, which delays an enhancement between 10 to 15 minutes compared to normal myocardium. But we know that the half-life of gadolinium at normal kidney function is 90 minutes, but it can also stay up into your blood radiologically for 5 hours. Let's take a look at this case. This is a patient who has a typical acute myocarditis. As you can see here, there's the peripheral on the late gadolinium enhancement. I like to use a steady state free precession, which actually shows it a lot better, but never rule out your stir sequence, because also it can predetermine and show you if there is or isn't any inflammation. Then you know you can add extra 20 minutes. Here is a case. Now, I want to also touch on CT perfusion versus cardiac MRI perfusion, or LGE. This is an interesting case. This is a 57-year-old male with an acute infarction of the anterior wall of the left ventricle. As you can see here, this is where they use dual energy. You can actually see there is no contrast enhancement there. You can actually see it here on the 2-chamber long axis. Now, when you come to look at cardiac MRI, it's a very small, subtle findings. So in this case, CT did show it quite nicely. However, you can actually see there is hyper-enhanced areas with both CT and MR, but with visual underestimation of the microvascular obstruction on CT, okay, compared to MR. Here is another one, a 79-year-old male with an acute infarction of the anterior wall of the left ventricle. You can see it's quite obvious. Look at this significant enhancement here. Now, when we looked at the microvascular obstruction areas by MRI, they correspond to the hyper-enhanced areas relative to the CT value, and it shows that quite nicely there and there. So here we can actually see that both CT is still not viable for my cardiac microvascular obstruction, or in cardiac relative to cardiac MRI. I still think cardiac MRI is the gold standard. Here is another case with a 54-year-old male with an anterior wall infarction. If you have a look at here quite nicely, late gadolinium enhancement at 20 minutes shows beautifully these hyperintensities there. And if you look at, of course, when they did the MRI, this was performed 5 days later. It actually shows it as quite small relative to what it is. And if you look at here on your T2 weighted image, it looks like enlarged. So here, this is a key giveaway. 5 days post PCI is actually too early to scan for microvascular obstruction. And also, you can also have microvascular obstruction without a coronary artery obstruction. And this is again what we showed before. You could or couldn't have an obstruction in the macro circulation, it's probably happening in the capillary areas. And here you can actually show that there is hyperenhancement at the late gadolinium enhancement, whilst up here on the coronary angiogram, it's completely clear and it is free of stenosis. Another example of a late gadolinium enhancement of the mid-lateral myocardial wall. This is necrosis. You can see that quite nicely there as well. Normal coronary angiogram. Then lastly, I want to touch on stress perfusion. Patients that end up having stress perfusion through coronary MR, at rest, it doesn't show that there is anything. On stress, it does show there is minor. Okay. However, when you look at late gadolinium enhancement after recirculation, again, there is no microvascular dysfunction and it shows no ischemic pattern. And remember, this is critical. At stress, it will show you this is usually 5 minutes, LGE 20 minutes. We image after ischemia. Always the infarct changes after the first 7 days. So usually when we saw that case before between the T2 weighted and the LGE, there was a mismatch between perfused and non-reperfused myocardial infarction. Ideally, always like to wait 4 weeks or at least 2 to 4 weeks below if it's an urgent case. And infarct volumes can shrink up to 25% of its initial size over 4 to 6 weeks as edema is reabsorbed and necrotic myocytes are replaced by scar tissue. After 6 weeks, the infarct size is relatively stable. Look at the left ventricular mass. Again, it's same. After 4 weeks, it stabilizes. Otherwise, the left ventricular mass increases in size, and that's what we saw before in the T2 weighted sequence. If we look at viable myocardium, you need time for the infarct. It may increase or reduce over time due to myocyte hypertrophy, but usually 4 to 6 weeks is really good, especially between perfused and non-reperfused and perfused myocardial infarctions. Of course, there are other extracellular volumes and techniques when you can look at T1 values when you're using Molly or Sholly sequences, especially between 1.5 and 3 Tesla sequence scanners. Be very careful of the measurements. And of course, usually up here, the T1 values are greater than 1,200 milliseconds for chronic and acute myocardial infarction. Usually around chronic is sitting around about 900 itself at about 100%. Thank you very much for listening to my presentation. I really appreciate it. To the Vietnamese Society of Radiology and Nuclear Medicine and to the president for inviting me. Please use this QR code. Take a picture. You can sign up to it and we give 2 free webinars a month that are fully accredited. Thank you all so much and I wish you all a pleasant conference, and I'm very apologetic for not being in beautiful Da Nang in Vietnam.